BW Healthcare World's podcast that is focused on the quality and patient safety. My name is Harvinder Narula, and my guest today is Dr. Parag Rindani, who is the Group Chief Executive Officer of Wockhardt Hospitals. Dr. Rindani has worked extensively on setting up quality management systems in Indian hospitals. He's been an integral part of NABH and JCI accreditation and re-accreditation processes. And Dr. Rindani has also successfully conducted programs on setting up infection control programs in hospitals using PDCA cycle in Maldives, India, and in Bahrain. Today, we will focus on our discussion about the promotion of something very, very important, which is the reporting culture in our Indian hospitals. So, Dr. Rindani, thank you so much for joining us today. It has been a pleasure to have you discuss this extremely important topic that we are, around the culture of reporting.
Thank you very much, Mr. Narula, for having me over. And thank you, Kaho, for thinking that I'm good enough to participate in this podcast. I'd be happy to sort of enlighten the people who are listening and to kind of see and understand what exactly is a culture of reporting errors and how we can benefit as a nation. So back to you, Mr. Narula.
Yeah. So, Dr. Rindani, before we get into the discussion, there's this concept of just culture. Can you explain for our audience what does this mean and what are the key elements of just culture?
So fundamentally, a just culture is exactly what it sounds like. A just culture is a culture which is just to the person who is doing a job in a healthcare institution or in any institution. It emphasizes accountability. It emphasizes the fact that we need to learn from our errors. At the same time, it does differentiate from at-risk behavior or reckless behavior and does have punitive sort of things in place for that particular aspect. But generally, it's a non-punitive culture. There's a very big guru of healthcare quality, or rather quality, who W. Edwards Deming, who said that all mistakes belong to the system and the system belongs to management. Now, if you think of it, we constantly keep berating system kharab hai, system kharab hai. System banaya to hum hi ne hai na, it's we who've made our system. So I think a just culture is one that, while it emphasizes on accountability, it pushes for people to get trained in that particular skill set. It also recognizes the fact that most errors are systemic. People don't come to work to make mistakes. They come to work to try and do a good job at what they're good. Now, what are the elements that typically would substantiate that an organization has a just culture? To begin with, first of all, there has to be fairness. The principle of fairness basically distinguishes whether this was a genuine mistake or was it an intentional violation. Somebody just forgets to do something, or is it like genuinely because of overpressure, too many patients, complex systems and processes? That's one of the things. So fairness is extremely important. I think the second thing, which is sort of critical here, is transparency. How do we ensure that people down the line, at our CEO's position, CXO's position, how do we ensure that people down the line perceive the transparency that is there in the system? So whether it's a consultant who makes a mistake or it's a rookie nurse or a rookie technician who makes a mistake, how do we ensure uniformity and transparency? The ability for people to speak out without fear of being punished. That exactly is what a just culture should be promoting. And I think the last thing is, a just culture essentially predisposes towards learnings. In our country, we are very scared to speak out, but we must see every error as an opportunity for improvement in the system. And till we don't recognize that, and that's what accreditation and quality in healthcare is all about, till we don't recognize that, I don't think we're going to succeed as a nation.
I totally agree with you. I mean, I know that nobody would want to make mistakes knowingly. So these are errors. And, Dr. Rindani, since you spoke about that this is a problem with the system and system needs to evolve over a period of time, even though we have made the system, but it has to evolve with time, learning from situations that we undergo. In your experience in hospital management, as a hospital management professional, How do you think we can promote this culture in an organization? Because at the end of the day, this has to come from within.
Right.
You know, there has to be a change that emerges out of a conscious effort. And also, if you'd like to elaborate, using some example or something, we'll be happy to take that.
Uh, I'd probably use an example as a user case to kind of drive home the point of how we promote the just culture system. So, first of all, we've sort of eliminated writing the name of the person who's committing a medication error in the system. Why we've done that is that while we do know what's happened because it's all there in the system, we try and not label people as people who do errors. How do we promote that? I think essentially right from the time that employees join the organization, from day one, typically all healthcare institutions, all institutions across the globe do have what we call induction programs. You get a person, you've got to get that person acclimatized to your systems and processes. As you know, no organization is uniform to another organization. And therefore, when we start inducting the employee within the organization and then within the department, we have a buddy program for our nurses and for our technicians. We essentially talk to them about the fact that it's okay to report. We don't say it's okay to make an error, but we do tell them it's okay to report, because if you don't report, the cascade mechanism might harm our patients more. So that is one communication from the very top, that it's okay to report, and we will look at the problem and see whether there is a systemic error at play. I think essentially the other thing is leadership commitment has to be not just bespoke, but it has to be actually walked. You have to ensure that people don't get terminated because of errors. One does appreciate the fact that there is a life at stake, and that's why healthcare administrators over the world work jointly with nurses and doctors and technologists to ensure that systems and processes are foolproofed or idiot proofed, actually. But nonetheless, when something does happen, you can't just take a person and say, please leave. Unless it's intentional, unless there's cause for that. I think medication errors is one area where we are learning still to constantly cull out this culture. There are errors which are just transcription errors. You made a mistake in just putting a one or a zero, which could cause a life to sort of fade away. But at the same time, I think that this is one area. Falls is another area where we've managed to sort of promote the fact that in case a patient does fall, we need to report it so that we can introspect and see how to strengthen the process. I personally believe that there are mistakes within healthcare. The To err is human. The Institute of Medicine report very clearly gave statistics as to how many people die on a daily basis in the US. Indian data is still not forthcoming, but till we don't speak up, as they say, and say, I made a mistake, I think that's one. The other thing is, I think, anonymous reporting mechanisms, which are more and more coming in place with the digitization. I think that's another area which is coming of fashion today, so to speak. And I think the last important thing is ensuring that the grassroots level people are actually involved in hashing out the errors that happen within their wards, within their ICUs. Then that way they feel, okay, I made a mistake. It didn't cost a life, but this is what I should tell people. You speak up. And I think these are the ways in which we have been able to promote a just culture within the organization, Mr. Narul.
And Dr. Rindani, it is very interesting because you were talking about culture.
Hmm.
And we while we speak that the doctors, there is no punishment for making an error because it is
Hmm.
an error at the end of the day. But is just I think they could be feeling that they would be assuming a bad feeling of making an error.
Hmm.
The ego gets hurt, and probably that is one reason that they may not be coming forward to report an error.
True, very
What
true.
would other people say about it? What would their team members talk about? Even though it is anonymous, you know uh, that feeling of being on the wrong side uh, could be stopping them. How do you make sure that people then are forthcoming, they get over this human psyche of not feeling bad to report for the benefit of the system?
So, let me tell you about the way we started working with accreditation and healthcare quality. Wockhardt Hospitals was one of the first hospitals in the country to get accredited by Joint Commission International way back in 2005. National accreditation was just starting. And in 2005, it was very difficult for even clinicians to accept that, no, my patient has an infection. Now, we are not even talking about the fact that, how did the infection happen? Is there a personal involvement in causing this infection? Is it healthcare associated? Is it human interface related? Was there something that we didn't do in time, et cetera, et cetera? We are just talking about acknowledging the fact that there is an infection. There is a healthcare associated infection. Now, from that time, and I think to that extent, the growth of national accreditation in our country has helped us a lot. Organizations like CAHO, they have done their bit in ensuring that people understand. So I think it's been a very slow journey, if you ask me. People actually talking about it. Even today, in tier one cities, while you may see a lot of this, in tier two cities, you do have a lot of punitive culture. Oh, she made a mistake, let's just throw it out. Because there's a complexity to how you are perceived in that small community. In a Bombay or a Delhi, it's a much larger platform. People don't mind leaving because they find jobs. But I think what is critical here is that as management, we need to acknowledge that if we create complex systems because of multiple reasons, we've got multiple payers, we've got multiple consultants, and all of that. The moment we start sort of complicating our systems and processes, it's a short recipe for disaster. We personally have found, like, we use a smock when our nurses are preparing medications, which says, "I'm preparing medication, do not disturb." It's a yellow colored smock. Now, what happens is it drives home the point. The doctor is loath to call out to that nurse and say, "Hey, come on rounds with me." So by creating more and more visible differentiators, we first of all strong arm the actual process. In healthcare quality, whenever you want to improve quality, you try and improve the process. And I think that's something which is critical. When you strengthen the process, you automatically make it easier for nurses, doctors to come up and say, "Hey, listen, this system is good, but we could strengthen it like this." So there's a lot of equity which is built in from the grassroots level, and that promotes reporting throughout, from the senior most consultant to the rookiest nurse or technician who's there in the system. But I think management needs to accept that if something like this does happen, we need to acknowledge the fact that maybe our system needs a little tweaking. And that's what we set up these committees for. We hash out the data, we do quality improvement projects. When you do a quality improvement project, Avitus Donabedian had once said that structures and processes will drive outcomes. Now, when you review your outcomes, you're able to correct your structures, you're able to correct your processes. And I think that's what management needs to focus on. Management also needs to focus on not just using accreditation as a 5-7 day phenomenon. Accreditation has to be part of the DNA. And once you make it part of the DNA, the culture of safety, the culture of reporting, this non-punitive culture that we speak about is something that automatically sets in. We've seen it at our group of hospitals, at Wockhardt Group of Hospitals. We started working with the Harvard system way back in 2001, when, healthcare was not, quote unquote, this, what should I say, complex, structured, hierarchical kind of a sort of a business. We started working on that because we do believe that safety has to be integral to everything that we do in healthcare.
Uh, Dr. Rindani, what is very interesting is that while we talk about a non-punitive culture for reporting errors,
Hmm.
from the patient's perspective, it's a question of life and death.
True.
And we're talking about transparency. You know,
Hmm.
how do you balance between the transparency within the system versus what is being told to the patient? Because for them, and we've seen instances of violation against doctors,
Hmm.
so, while we want the doctors to report these errors, but they're also scared from not within the hospital system, but from outside. How do you, as a hospital administrator, balance this?
So, primarily the entire reporting system at a national level, which is driven by for example, let's take medication errors. Okay. Now, these are things which are not seen so much. And when they come up there, it's usually a big hue and cry. But if you look at medication errors, for example, CDESCO, that's the CDSCO, actually has a anonymous system for reporting. Okay. When it happens to an individual patient, invariably doctors speak up. They do go and tell them, this is what has happened. Uh, there might not be a very transparent thing stating that, did A write it wrong, or B mix it wrong, or C dispense it wrongly, or D administer it wrongly. I'm not putting names to A, B, C, D. That level of transparency may yet, need some more time. But the entire focus of saying that it was this report that led us to give this, and that's why the patient's condition is this, it's a known complication, quote unquote, or it's something that happens very rarely. I think that's already come about because patients are extremely educated over the last 20 years since accreditation has started in India, NABH. The entire focus on patient rights and education is something that's really come up in a strong way. And as administrators, we are also happier. I won't say happier, wrong word, strike that. I think our conscience is a little bit calmer when we acknowledge our errors and speak it out. It's just you can't keep hiding things from the stakeholders. The patient is my primary, I mean, is somebody who I primarily will need throughout the life cycle of healthcare. I need to ensure that these patients are part and parcel of the safety and quality journey of our healthcare institutions. And that is why today there are multiple fora which actually work with, there is a patient for healthcare safety forum. There are patients who actually sit in on committees within the healthcare institution and give feedback for improvement of things that are supposed to happen within the hospital, which is very local because they are local people. I, for example, chat with our patients on a regular basis. I have a patient, rather a relative, whose father-in-law comes for dialysis 3 times a week. And invariably, I keep meeting up with this lady and I keep asking her that, let's call her Mrs. S. I said, Mrs. S, how are things? How's your father-in-law? It's a typical elevator conversation. After about 3 months, I realized that I need to go to the dialysis and sit down with her and ask her, Madam, what is happening with your patient? Is he improving, not improving, and so on and so forth? So these conversations help. And I think leadership is only called leadership when it goes out to what we call in Japanese the gemba, going to the shop floor, acknowledging what's happening there. If you just sit, if you become an armchair CEO, you don't know what's happening. And this is where I think the patient trust, the patient engagement is something that leaders need to learn to do. People do respect if there are mistakes happen. There may be a case later on, but they do respect transparency. And we, most of the times, we do come up and say, this is what happened. Now, if it's something that got arrested and things didn't reach the patient, there was no harm. It's something which we don't really come up and say, hey, this could have happened. But if something has happened, we do speak about it.
Yeah, as long as the intent is very clearly known that this was not intended, the intent was very clear, and this is just an accident or an error.
Yeah.
Uh,
But
Doctor,
on the same note, you must acknowledge the fact that not all patients and not all relatives are going to be very calm about it, and there are what we call code violets and purples and beating up of that happens, which unfortunately is very very unprofessional. I mean, if you consider the patient ilk to be a set profession within itself, I don't think beating up healthcare professionals is ever going to be the answer. So on that is something that we do have systems in place to prevent that, but we just need to be cognizant of that as well.
absolutely, absolutely. Dr. Indani, we've been talking about just culture, we've been talking about patient safety. How does the concept of just culture or the culture of reporting the errors
Hmm.
in the long term impact the culture of safety in our healthcare system?
I think it's only when you report do you enhance the culture of safety. We, for example, for the last 5 years have been doing a survey on the culture of safety within the organization. We have purposefully tried to link it with the errors that happen. And the culture of safety doesn't specifically talk about errors. It just talks about the culture, whether there is openness of reporting, whether you feel comfortable that if you report something, you will not get penalized, even if you report something which is not done by you, but something that's in the system. If you see, say, for example, if you see your superior reporting something, we've actually seen that the more we've worked on better reporting, the more we've seen say sort of negative incidences reducing. And let's accept this. If I go today to SV Road in Mumbai at Malad or Goregaon at 2 o'clock in the morning, nobody's going to stop at a red light at 2 o'clock because they know that our esteemed traffic police are not looking. But you go to any other foreign country, they'll stop at 2, they'll stop at 4, whatever time. So I think the culture of safety comes also from within. I think people are now acknowledging that not only is reporting good, but if it's going to strengthen, nobody likes to have a sleepless night. Let me tell you, healthcare workers go through a lot of difficulties when something happens to a patient, let alone because of an error, even otherwise. We've seen this in COVID. We were one of the first hospitals to kind of come under fire for COVID, as you would recall, Mr. Narula. We were also the hospital which kind of came out with flying colors with the lowest mortality, anywhere in Mumbai in private institutions. All three phases, phase 1, 2, and 3 of COVID. What we've seen is that whenever a COVID patient used to die, staff used to break down. This is not because of any error. This is just the fact that there is a human touch to healthcare professionals. And when something really goes bad, healthcare workers really, really suffer. So, to your point, I would say definitely healthcare safety increases when there's a better reporting culture. Otherwise, it's just sweep it under the carpet. Who's going to get to know? There are institutions when we go for assessments, there are institutions when you ask them to show how many medication errors have you had, they say, sir, we had 3 in the last 3 years. Now, that's not physically possible, you see. That means you're not looking. And you will only see what, like, if you don't know what you're looking for, you're never going to find it. That's the whole problem.
Got it. And Dr. Indani, in a hospital system, especially when you're looking at errors and avoidable errors like falls, etc., you have different stakeholders working in a hospital. It's not just the doctor or the nurse. It's the support staff that is there. It is the housekeeping staff that is there. It's the security staff that is there. And errors could happen at different levels by different people responsible in an organization.
True, true.
How do you uh, manage to implement this concept of just culture in a complex system where everybody has a role in the hospital, everybody has a role to play in the safety of a patient? Uh, as an administrator, how do you manage it?
Okay. Uh, as you know, Mr. Narula, today's business is comprised of focusing only on the core competence and outsourcing what is not really core. So if as a healthcare company, I can't really get my people to cook well or secure things well or clean things well, I will outsource the food and beverages security and the housekeeping services. In these scenarios, if you open the NABH chapter on HRM, which is chapter number 9, they talk about two sets of people. They talk about staff and then they talk about employees. Now, most of the people are my employees, but I do have what is called staff. I do have consultants who go to different places, other hospitals visiting consultants. I do have outsourced people who are not on my roles from an employee point of view, from a Provident Fund point of view, but they do work with my patients. At the end of the day, the focus is not who pays whom. The focus is patient के इर्द गिर्द कौन जाएगा. Now, once you keep the patient, or what we call the patient-centric culture, once you keep the patient at the center of everything that you do, rather than a register or oh my God, he broke the wheelchair. Now, we've got away from that time when things used to be departmental. Today, everything is institutional, and patient is at the center of all of this. Now, when you keep the patient as the epitome of everything that you do, everybody falls in line. And that again comes from the top. The moment you start including security, housekeeping, any outsourced staff in the birthday celebrations along with the employees, there is automatically a sense of ownership. When you have an induction which is common to all, irrespective of whether company A is paying you or company B is paying you, there is automatically a lot of involvement. I have actually found that my older outsourced staff are far more quote unquote indoctrinated, if you may accept that word, as compared to some of my newer employees. So it's all about not who's paying you, but it's all about how you treat your outsourced staff and how you work with them. To that end, I would say that we've managed to interweave a beautiful culture of safety, irrespective of whether it's an employee or as an outsourced person. Our consultants' reporting of errors has really gone up. They've started acknowledging, all of our people have started acknowledging that safety is the one thing we cannot compromise with. Of course, the fact that patients have become more educated, they have also started contributing. One other thing that we constantly work on, sort of to enhance the safety, one of the persons kind of which you rightly pointed out, is the patient relative. You see, so somewhere I'd read this phrase, nothing about me without me. So the moment you are able to involve the patient and the caregiver in the rendition of care, in the fact that he's supposed to have, this red medication as the antibiotic and he must have it after food. Your medication lockers must be kept locked, the side rails must be kept up. I think this is when there is a lot of buy-in from everybody, and then they see the same thing. So I have patients who actually reach out to nurses and doctors and say, hey, you didn't wash your hands before giving this injection, be careful next time, I'm going to take you up on this. So I think culture of safety is both within as well as at the relatives end. And I think that's something which is really improving our country. Outcomes, of course, we would love to have a central repository of all this data so we're able to benchmark against the world. But I guess that's something which in the next 2, 3 years, CAHO we will work at. So
I think
that's to that point.
it's very beautiful. You brought out a very important point because, people have to start demanding safety,
Absolutely.
and that
Absolutely.
is when the institution will start responding to it. So I think that is something that is needed. Now, Dr. Indani, when we're talking of the culture, and you said that, many ways, you are building up a system where there is anonymity when it comes to reporting. What are the preferred ways of reporting? Is it in writing? Is it going to your superior and reporting that something has happened? How does it work?
So it's that's a very fine question, because at the end of the day, that's what we don't want the superior yelling at the quote unquote person who's made a mistake. I didn't want to use the word offender, but it almost got out. Uh, I personally believe that there are enough anonymous ways. There are boxes which can be kept. You don't have to be very tech savvy to do this. Uh, we actually are looking at a system right now wherein you're able to, without a login, just go to the intranet of the hospital, the intranet portal of the hospital, without putting your employee ID or anything. Just log in without a login. Also, just go to the computer, put that down. The reason why we want it down in writing is because every error in healthcare or anywhere in any industry needs to be drilled down to, so that we are able to do what is called the kappa, or the corrective action, preventive action. See, we don't want the same mistakes to get repeated again and again, right? I mean, एक बार if your tire has less air, and that unfortunately happens on the day it's your wife's birthday, you're never going to forget that, sir. So it's like that. So I think what is very critical is we need to look at our errors, we need to drill down on the errors, and we need to do what is called a root cause analysis. Once a root cause analysis is done, we need to correct the system. As I said, all mistakes belong to the system belongs to management. यदि हम सिस्टम को करेक्ट नहीं करेंगे तो सिस्टम कभी सुधरेगी नहीं. It's
Correct.
the same thing how if you talk about the quote unquote the national system. So we keep blaming the system, but so written is the correct way to report errors. Oral works, but then somebody's got to scribe it down.
And Dr. Indani, you were saying that the errors don't need to be repeated or should not be repeated. Now, there is this concept of second victim.
Hmm.
Can you explain what it means and how can such incidents be prevented and addressed appropriately?
Okay. Second victim essentially is a healthcare worker who has been the um, who's been traumatized by any sort of error that's happened at his or her or their hands. And, this incident has actually ended up harming a patient. This person who actually has committed the error, or because of whom, or he's being party to the error happening, let's put it like that in a passive sense. These people have a lot of emotional and psychological trauma because they perceive that they did it. I've had people come up and say, Sir, I killed him. Now, we know that's not true. We know that there's a larger thing at play. But at the same time, there are patients also who scream and say, आपने मेरे पिताजी को मार डाला. You killed my father. You killed my wife. Uh, Doctors, nurses, technologists, administrators also. Anybody can be a second victim if he or she or they have had any sort of trauma because of their involvement in an error. Now, why do we talk about this so much? Because recently, over the last 5 years, accreditation bodies have started talking about it. We never labeled these people second victims, but we've always looked at them. We've looked at them in terms of peer support. We've looked at them in terms of counseling. We've looked at them in terms of a fundamental organizational support that if you need to go to a psychologist to sort of get out of this and get more coping mechanism built into you, we will support you as an institution. Because we do acknowledge that any sort of trauma that happens to my person, quote unquote, it's essentially vicarious, right? He or she is doing a job in the hospital. And whatever happens, it's our job to support our people. So that's what the second victim sort of ethos is coming out from. I think strong counseling mechanism when the thing happens to prevent this trauma from happening. Acknowledging that these people are also victims, that is also very important. And finally, teaching them how to cope. You would not believe it, but I've had second victims who've gone on and actually become stronger champions of safety because they've said this happened. They say this happened and this is what I felt and I would not like you to feel this, so let's build a stronger system. These go back, and these are grassroots level nurses and residents, doctors, and so on. So I think that is something that second victims can become very powerful champions of preventing errors and promoting a culture of safety in any hospital after they've gone through good counseling sessions.
Dr. Rindani, you've touched upon a very sensitive topic because we saw that during pandemic.
Hmm.
Because I think the saddest part of a doctor's job is when they know that they can do something, but they are or were not able to do that because of lack of resources, etc. And that can be very mentally challenging, and that can impact their future work ethics, etc. Because they may not be able to, they would be very fearful of doing something, and that's very bad for a medical practitioner.
Yeah, I agree with you. I think the pandemic, while it's been great to get acknowledged by everybody in society, but then the recent incidences don't really lend to too much that. So these are all passing fancies. Uh, I think every professional has to do his or her or their job. Healthcare is just another profession, and I think that we all need to continue to give our best, make it as safe as possible. There will always be some threshold that we need to constantly try and reduce. And I think while it is good to feel respected and honored by society at large during such incidences, what is very critical is not to forget that at the end of the day, it's between you and that one patient where you need to prevent errors. So
Mhm.
in quality, we say get it right the first time right, every time right. And once we're able to focus on that as a fundamental ethos of how we do, that's what we do at Wockhardt. It's good to celebrate, these patient safety days and this and that. But remember, the crux, as I always say it, is that if you've got a policy which talks about two identifiers or two people giving a high alert medication, it's only relevant when you stop at that 2 a.m. signal. When at 2 a.m., when Alema is alone in the ward, or the other girl's gone up to sleep, when she actually wakes up the girl and said, "Hey, I'm giving a high alert medication. I'd like you to come with me. I'd like you to witness that high alert medication dispensing." So I think this is where we need to reach. जब तक वो 2 बजे वाला सिग्नल पे हम रोकेंगे नहीं, I don't think we're going to be a very safe country.
Okay, and one more thing again. I'm sorry, I've got certain things that is coming to
Please,
our mind,
Mr. Narula.
and uh, there could be a situation where it's a chicken and egg story where it is okay to safeguard against errors, a doctor, but you also want him to be fearful of not making mistakes. You know, so how do you create that balance? Uh, कि
I
मतलब
don't,
आपको
I
it should
hear
not be,
this.
it should not be that he's indemnified
No, no, ऐसा
for
नहीं
any
होता.
error.
It doesn't work like that. I don't think
So if you can
You might
explain it
have
for
these.
a layman how it works, sir.
Okay, you might have these anecdotal stories of this doctor death and this and that, but essentially 99.99999% of people come to healthcare to do good because they really want to do good. Uh, you can keep such things in places which are elective. Like, for example, we will not allow a patient to be moved at any of our Wockhardt hospitals till the pre-anesthesia check is done, till the consents are signed, and so on and so forth. Try telling this to a doctor who is in a 30-second time walk where he's got to resuscitate a patient. He's got 3 minutes to get everything done. And at that point in time, if I start showing him a stick and saying, hey, you don't make a mistake, right? So I think there are situations when you can tell them that, we need to work like this and those need to be driven at. But there are some situations which you can't really put sort of pressure. I think the other important thing also is that wherever we have found in healthcare, this is not about my group of hospitals, across national, international healthcare, wherever we found that there are systems which could break down there and which are critical, their accreditation systems have put in maker checker things. So, for example, I don't know how often you go to the locker to the bank, but whenever I go to the locker, I will remove my key, put the key again, check it again before I leave. So you have two keys to that locker, right? Now, these two keys are the maker checker. When, for example, we're giving a high alert medication, when, for example, we are starting a surgery and we want to ensure that it is the correct kidney that we are removing, the diseased kidney and not the healthy kidney. When you're talking about giving a medication for which a particular patient is allergic, you have artificial clinical decision support systems in place. You've got databases in place which help you to sort of do a maker checker on these. Now, what is very critical is I have never believed that a danda works. I don't believe in dandaism. I've always believed in the power of dialogue. Probably it's because of my 24 years, 23 years at Wockhardt. We don't believe in a concept of, go around with a stick. Personally, if you ask me, consultants need to be spoken to, nurses need to be spoken to, technicians need to be spoken to, and they acknowledge the fact. If you're senior, if you're speaking to them, they do come up and say, sir, these are the challenges that I have to do what you're asking me to do. Can we solve these also? And that is the correct way, through an open dialogue on at both ends, wherein you acknowledge their difficulties and they acknowledge the fact that for patient safety, we've got to jointly overcome these challenges. Now, not everything can be addressed, so you try and use systems and processes, you use digitization, you use artificial intelligence. Thankfully, the world is evolving. You must remember that the risk of dying in an aeroplane is far lesser than the risk of dying in a healthcare institution. So we need to quickly pass the aviation industry and quickly get safer and better.
I'm so glad that we are using the word culture everywhere because, like you said, that if the patient needs attention in 30 seconds or 3 minutes, you can't go around telling the doctor that you need to be careful. That has to be ingrained in his mind anyway. So it's a part of what he does all the time. I think culture is the right thing to talk about. My last question to you, sir, before I let you go is, you spoke about that when you talk about the patient, it is that nothing about me without me.
Gee.
So how can we engage patients for patient safety and inculcate a sense of, or essence of patient engagement for ensuring a healthy mechanism for reporting incidents?
So I think here at the very outset, the first thing that comes to mind is education. I think patient education before the patient comes in, we actually now make videos and reels, thanks to the power. Today's youth is very, very tech savvy. Today's youth is very empowered in terms of the ideas that they have. Uh, a good open communication, good education and empowerment of our patients, where we are able to speak to them and say, this is the reason why we will do this. We don't just want to say your name aloud and say Parag Rindani left knee replacement. We say it because of this reason. जब आप पेशेंट के साथ रीजंस के साथ बात करते हो, there is a lot of acknowledgement and they appreciate it. So we, for example, at the Wockhardt group of hospitals, say a small prayer before the patient goes into OT. Now we tell them that we are not saying this prayer because of anything else. It's an agnostic of any religion prayer. It's just a simple English Hindi prayer. But we also tell them that, sir, when you go inside, you will be spoken to, your name will be asked. He's saying, I said, we explain to them, क्यों पूछने हैं? क्योंकि हमको गलत पेशेंट की सर्जरी नहीं करनी है, गलत organ की नहीं करनी है. So there's a lot of engagement that goes on. The second thing is this entire concept of consents being merely just taken and signed as a piece of paper has gone. There's a lot more of education that happens when consents are given. And this empowerment that they have the right to refuse whatever treatment they've chosen at any point in time is something that helps. But I think the most important thing is listening to your patient's feedback and talking to them constantly till you don't like there are patients who will write on our NPS surveys that this doctor did not ask me about this. We go back to the healthcare worker and say, hey, listen, these are the things that we forgot to do. The checklist does help, but sometimes the checklist just becomes a tick, which we don't like. So I would rather have a employee empowered, patient engaged kind of mechanism rather than just having a checklist to tick things off. But I personally believe and education, patients are beginning to understand that they have a voice, they have a role in their own safety. And today's patients are generally also, even the ones in the villages have got internet. So I don't think that urban rural divide is also much there. However, uh, we must acknowledge that healthcare has also changed, it's become more complex.
Mhm.
Uh, Devices, medications, delivery mechanisms of healthcare have become more complex. So we must keep on building safety in our healthcare processes. Till we don't acknowledge that safety is one of the first things that needs to be there in healthcare, we are going to keep failing. So I think safety is important, access is important, equity of people is very important in healthcare. But I would still say safety comes first. That's my take on that.
Dr. Indani, I think, one big takeaway from here is that safety, especially in a medical environment and a hospital environment, is a collaborative effort. Not just collaboration between the medical staff versus non-medical staff, but also the patient is an integral part of the safety process. And, some of the takeaways are that first, we need to understand that no one is making a mistake knowingly. If they were to know, then they would not do it in the first place itself. Second is, if there is a need for transparency and uniformity of a process that allows the doctor or any other staff involved to speak about the error that has happened without the fear of being punished, with the intent of learning from it so that the error is not repeated, not just by this person, but by anyone else in the hospital. It's not about that one particular person. And I think, the patient, like you mentioned, needs to be involved in the process so that we can strengthen the process and make healthcare even more safer than what it is today. Dr. Rindani, thank you so much for your time. It is such a pleasure to have spoken with you and get these insights into how the safety process works.
The pleasure was mine, Mr. Narula. Thank you very much for engaging with me, and thanks to Kaho for allowing me to speak. Thank you so much.
Thank you, sir.